We're going to say welcome to those of us who are joining us online for the ICU Skills Conference. So we're first talking about fluid balance and vasopressors. So the purpose of this talk is really to get you thinking about fluid the way your body thinks about fluid. A lot of times we have opportunities to give saline or give something else, or maybe you see a patient that's a little sicker and they have different medicines going. We're going to talk about the medicines you would typically see used, why you might see those used, and the better part of judgment is when you shouldn't use them, and things you should do before you use them. And those are typically where the experience of a good nurse comes into play to kind of temper the decisions of a resident or someone who's not really watching closely that's ordering these things. So you have a lot of power. That's the point of my first slide here. What are we going to talk about? We're going to talk about the physiology of healthy vasculature and control mechanisms, situations when your vessels may be dilated when they shouldn't be. Do we give fluid? Do we give pressors? Which comes first? Basically, we're going to talk about the nervous system, different drugs, reasons they don't work, and then your implications as a bedside nurse. All right, so first things first, turn on your clickers. There's a little button to the left of the Elmo that should turn it, so there's a little faint red hue to it. And what I want to do is we're going to play with this a little bit and see if this works. This is the first time we've used this with it, and we're finding some glitches with the display equipment here, so I apologize. But I want to see if we can make this all work here. So, step one here, I currently work as a inpatient, outpatient, student nurse, or other. So feel free to choose your options there, and let's see what happens here. Let's get some statistics and we can see how those look. All right, so everyone has done their thing. Okay. Let's see if we can see what you guys all are doing here. I'm not sure it's going to show up for you guys. So 18 of you are inpatient, 2 are outpatient, 7 are students. Hey, that's awesome. Excellent. You guys are lucky to be here. You know why? Because when I was a student, I would have killed for this stuff. This is good. And then there are 5 that are other. So either, I'm assuming, management or NPs or not in nursing specifically. So cool. Very good. All right, so it works. Yeah. The question is, can I get out of that? So in order to get here today, this is more important question. And let's see here. Sorry. On 3, 2, 1, go ahead and vote. Okay, so let's see what we got here. 3 people walked 500 miles. Great. So most of you, 17 of you are local, 5 are over, so 50 to 100, and then 5 came pretty far. So I was talking to some of the people before, and it sounds like someone came from upper areas in Minnesota. Anyone come farther from there? That's probably it. That wins something. I mean, that's legit. That's some dedication right there to be here today. So thank you for all being here. All right, so let's go on. So in my current job, I use vasoactive medications. So I'm going to set this up as a yes/no question, and you can just decide yes/no. So just wait a second here, and we will be able to wait for it. All right, go ahead and vote. But you have to do yes or no at the bottom. I did. There you go. Okay. And I'm not entirely certain why you're not seeing the results. I apologize, but it's a little quirky. So we'll find that of the 28 respondents, 22 do use vasopressors and 6 don't. So most of you do, most of you have some familiarity, and some don't. So that's great. What you'll find is that everyone's going to interpret these a little different as far as how you use them, when to use them, and that's okay, because you're going to work with different people that have different paradigms of views on why you would or why you shouldn't. and that's okay. So let's talk about vasopressors. A vasopressor is a catecholamine, which is a fancy word of the day here, which in a perfect world will exert a central and or systemic effect to alter a patient's hemodynamic status through the use of direct stimulation. Oh my gosh, you guys stop listening because I already stopped listening. Or by indirect neurotransmitter stimulation on target adrenergic sites. Okay, yeah, but what does that really mean? A vasopressor is something that is going to take your donut and make the hole smaller or bigger. That's all it is, okay? So when you think about this, you have a hole, and this is your blood vessel. It's as simple as that. You have a normal size hole in your donut. Sometimes it's bigger, sometimes it's smaller, depends on the size and type of donut, right? So if we're going to look at our body with all the crazy things that happen, there is so much that influences your blood vessels, the way they work, why they work. If you go outside and it's hot one day and come inside in the air conditioning, that changes it too, right? So environmental things have a huge play on it. But that said, it all goes down at the basic level to what your body is trying to create, a homeostatic environment where it will give you the end product to the end organs, which is good perfusion, a normal blood pressure, good urine output, good flow to the skin. Those are all the things we're trying to get as our end results. So when you're assessing a patient, really you're just not worried about how you got there. You're looking at what you got at the end result. But when it goes wrong, we have to go back a step and figure out, okay, why didn't that work? What of the things can we adjust? Some things you can't, right? If your patient's septic and they have something going on that you have to figure out and identify the cause of before you treat, that's one story. But our purposes are, let's say, a normal, healthy human being that has nothing abnormal, they're going to have the renin-angiotensin-aldosterone system. The things that you can address with that would be your kidney function. You can use medicines to alter that, obviously. Vasopressin is another thing that is very effective in this. It's carotid, venous, and atrial triggers will release the antidiuretic hormone, which basically will make you hold in your pee. That's pretty much about as simple as it goes. Your body does that naturally, both to help you control how much volume you have in your tank, so you're not just naturally drinking water and just peeing it right out. Your body needs some of that stuff, so it's kind of like the toll booth on the way out. So you need some of that to keep it working. If you have a little baby that's peeing at night every night, you can give them some ADH so that they don't wet the bed, in fact. So legit, you can actually do it. It's not a bad parenting thing, don't judge me. I'm not saying I did that, but you can. So atrial and brain natriuretic peptides. So your brain and your heart are actually more than just, they talk about, oh, think from your heart. It's like your heart can think. It actually knows stuff. Your brain knows stuff beyond your subconscious. It actually releases hormones that specifically will tell you, I think you're a little bit wet today, or I think you're a little dry today. We look at those in heart failure with something called a BNP, but that said, your atria also release something, atrial natriuretic peptide, and natriuresis, just to make sure we're on the same page, Na, so the Na of that is salt. So when you natriurese, you're basically diuresing salt. If you're kaliuresing, with his K, would be potassium. So most of the loop diuretics that you probably give more frequently, those are actually kaliuretics, they're not so much natriuretics by the fact that they're in the loop. But that said, they both do both features, so just keep that in mind. It's just basically taking the word diuretics and getting more specific as we talk about it. So every time you go to a conference or you have a presentation about, best 5 ways to remember this or that, there's always these really crazy acronyms. And decreased vascular tone, I couldn't find anything specific as a cool acronym. So I made one, and it just happened to be ODDCASH, and I'm going to call it Odd Cash, okay? But I tried to figure out all these really cool different ways of that and monikers, but we're just going to go with it. So you get a new one today. Never heard before, Odd Cash. If it becomes famous, it's being recorded. It's mine. Okay. So overdose or medications, this is very common. This is situations where you can take a person and give them medicine and watch immediately their blood pressure is going to drop, right? That's just, we all know that. We see that with Versed, Diprivan, other sedatives, anything that's going to relax you neurologically. But that said, they're also going to take the neurotransmitters that signal it and say, just chill out. Off to sleep you go, pressure goes down. Decreased sympathetic signals. Now this is something that could happen from not something you're wanting to have happen. This could be, neurogenic shock. You have a patient who has a transected cord or something. You're not going to get the signals physically to the areas that want that tone. And obviously your basal tone is going to go from being that normal donut and just relaxing, because it has nothing to keep it tight. So that's where we deal with an entirely different kind of mechanism. Decompensated shock, you have someone who is basically in an Addisonian crisis where they can't keep up with the natural process from the adrenal glands giving you the neurotransmitters. When you sleep at night, you regenerate those neurotransmitters. So the whole process of all these different vasopressors that we can give in a bag, we can actually look in our body and we find most of those in our own systems in smaller doses or a smaller version. They're all made from the same amino acid, and your body replenishes that when you're sleeping. So if you don't get sleep, they say, oh, you go pre-diabetic if you don't sleep for however long. Whatever. Basically what ends up happening is you basically lose all those neurotransmitters that are stored up, and then your body kicks into the cortisol mechanism, and that cortisol mechanism gives you what you need to keep going, because cortisol also comes from the adrenals. So that gets pushed in there and gets you going, but it also stimulates all your liver to dump out sugar, and it puts you in a pre-diabetic state. Yeah, okay. Well, you can deal with that, but the patient basically needs to get some rest. So all you people that work nights, keep that in mind, that you're actually running out of steam if you don't get enough sleep between. It actually puts you in a pro-diabetic state because you're using more cortisol. Well, more cortisol over time puts a lot of stress on your adrenals. So keep it in mind. So some people you'll see given a dose of hydrocortisone and all of a sudden they get better. Oh, look at you. That's because they just couldn't keep up with it. Too much stress that their body wasn't ready for. Cellular death and deterioration, obviously if the cells don't work, they can't do their job to squeeze or create pathways. If you have an MI, the heart can't squeeze anymore in a certain area. So all a part of the natural process. Acidosis, there's two things that the body doesn't do well with: when you're really cold and when you're really acidic. Those are basically the two big problems that if you can fix those, again, you're not I should make this an epic one. You're not dead until you're fill in the blank and dead. Everyone knows it's warm. You're not dead until you're warm and dead, right? And also if you're really acidic, your body doesn't know how to use those vasopressors. In fact, they don't work if your pH is too low or if you're too acidic. So there's different levels for each one, but as a general rule, if your pH is less than 6.9, pressors, you can go all day on them, they're not going to work. They just don't have any affinity to bind for those sites. They just can't squeeze. So the name of the game there is know your source. Why are you acidotic? If it's lactic acid, it means something's not getting perfused somewhere. So you need to figure out what the problem is. Otherwise, you're just putting Band-Aids on it. It's going to keep on coming. Sepsis or anaphylaxis, oh my gosh, what are we going to do, right? So the body's saying, get this stuff out of me. I don't know what it is, but I want it out. So open up the pipes and just get it out. And in the meantime, I'm going to exsanguinate all of my body volume, but it's okay, it's out. Well, the body is a little bit stark like that, but that's okay. Being stark is good when you have things that will kill you if they stay in your body, but it's also, it's kind of like the ICP in your head. The body tries to compensate to give you more cerebral flow, but it keeps on causing more and more pressure and hypertension, which just makes it worse and worse and worse. So it spirals out of control in different ways, in different directions at times. This is one of those scenarios. So we have to be very careful to know the source, reverse it, and then tell the body, chill out. And that will give you a chance to pull the pipes back closer. We'll talk about that. Hypercapnia, hypoventilation, heat. I had to have a couple things that have an H on there to make, otherwise it was odd cast. That didn't sound good. So there you go. So CO2 is a dilator. In fact, CO2 is probably one of the most effective veterinary medicine anesthetics you can use because CO2 is capable of being a narcotizing agent if you get a high enough dose. In fact, I'm sure you've seen patients that their CO2 is high, and it just so happens that you actually check a CO2 or an ABG on it because they're sitting there going, you're not breathing. You go, we should probably get a gas on them. And we check a gas and their pH and their PaO2 are the same. So it's like, your PCO2 is 90. Not okay. So if you don't breathe, you don't blow it off, it doesn't go anywhere. So it just sits there in your system. The body again goes, get this stuff out of me. I don't need this here. And it can dilate all the blood vessels until the body gets it out. So it's a negative feedback loop of how the body does a lot of things. It's good until it's bad, and then when it's bad, we stop it until it becomes good again. It just kind of finds that little happy medium of homeostasis. Oxygen actually is a constrictor, so when you give patients oxygen, you have to be careful. In fact, in pediatrics, oxygen can cause problems with the optic nerve because it's such a fragile nerve in the head, rather. You have to be very cautious in how you give oxygen. You can't just blast it ahead. Emergency medicine, as a general rule, likes oxygen more pre-hospitally than is ever necessary. As a paramedic for years, we'd have people on 100% oxygen, no big deal. And when you get to a hospital setting, they go, why would you do that? Turn them down to a nasal cannula. You go, well, that's ridiculous. I want a mask. I want to have high flow. They're like, you don't need that. They're fine. Their SAT's 100%. It's like, yes, but they're in crisis. You need more oxygen. No, you in fact don't, because oxygen oxidizes. It's actually bad if you have hypoperfusion to a tissue. It actually causes more damage than less when you reperfuse. So you have to be kind of careful. So we don't want to overuse oxygen unnecessarily. So all vessels are not created equal. So we have the arteries and the veins, and as a general rule, when I think about arteries and veins, I used to always think, okay, big red pumps out the red stuff, and then big blue pumps it back, right? So it's a little more complicated than that. And I learned about that more when I started taking vein when doing bypass surgery. I work in a cardiothoracic surgical practice, and one of the jobs that I have is I take the vein out of the leg to use for bypasses in the chest. So the surgeon will make an incision on the chest. They'll start working on taking down the artery under the left chest wall. That chest wall has an artery that dangles as well as on the right, but ideally you want to keep one of them there just because the blood flow to the chest for recovery, for the healing and all that for the wound, you gotta have some blood supply. You do okay if they're perfect, but if they're diabetic or obese or they have other risk factors, you want to at least leave one of those intact. So we tend to just use one of them. And it just basically free it up like a pendulum, swing it down and plug it into the area typically that's on the left anterior descending, the most important blood vessel for the actual left ventricular pump system of the heart. But the other ones get these less important. I kind of feel like my job is not as important as theirs, but I'm okay with that. They're heart surgeons. I take the vein that becomes everything but the most important one because they don't work as well. Veins are not arteries, but you can use them as the other temporarily. And by temporarily, that may be 10 to 15 years. That may be the rest of their life. But that said, everyone has a different failure rate. In about 10 to 15 years, that vein's probably not going to be, on a flip of a coin, it may be kind of going down the not working road. It's actually surprising if you see someone after 15 years that those vein grafts are still open. Typically, the reason that they wouldn't be open is because they got in trouble because they have heart disease. Well, you can get heart disease in veins as well as, if you're getting arterial flow through them, they kind of become hardened arteries, if that makes sense. So, point of that is they're not created equal. They don't do the same role unless you get crazy and do surgery to make them do the same role. Arteries are designed to be a resistance system. They're designed to be what your heart pumps out against. And because of that, they have a different mechanism. They're made of muscles. They have more strength. They're much more durable. They have all of the things that we look for in a general sense on our hemodynamics. Some use Swan-Ganz catheters. Some will use a lesser invasive option like an SCVO2 catheter, an SVO2 catheter, non-invasive cardiac monitors. These are all ways to get an idea what's actually happening when the heart pumps, what the blood is doing in the response to the pipes it's pumping into. And one of the main ones is something called systemic vascular resistance. And that's basically, if I have a hose, I'm out in the garden, and I put my finger over the end of that hose to the point of occluding it entirely, I have added basically an infinite amount of systemic resistance. So nothing's getting through there. But if you back it off a little bit, all of a sudden that flow that's kind of just trickling out, it goes flying, right? Because we've increased the velocity, because we've also given a smaller orifice. So when we tighten those pipes down, we take that basal tone and squeeze down. When we give pressors or give more volume in the same hose, if you take and crank the water flow up, it'll do the same thing, right? So you can give volume or you can give the squeeze, which is the pressor. It'll have the same result as long as you have a heart that can drive that much volume, or maybe should drive that much volume. Sometimes you can go a little overboard. So that's what the systemic vascular resistance is. Basically, what am I pushing against to get the heart to pump that blood out? And if you drop that too low, it sounds like, well, just drop it. The patient will be better. Well, not really, because if you take the finger off the hose, the speed that it's flying out just goes, whoop, falls down. That's your blood pressure. You lose your pressure. Your organs aren't getting perfused. You got the flower that you're trying to get the hose. You can't reach it, but yeah, now I got it, right? You just got to get all the way to the organs. So just kind of keep that in mind. Pulmonary vascular resistance is basically the right side of the heart pumping up to the lungs, the same concept with the systemic vascular resistance on the left. Not as important in general sense if your heart works well. It's more of an issue if you have pulmonary hypertension or if you have right heart strain. Arterioles constrict, they basically adjust and move, and they give you a little more of that dynamic nature. Cellular oxygenation and high hydrostatic pressure are key elements of that, and that's really how you feed the actual arteries, is through the blood vessels. And imagine that's how you squeeze there. That's how it gives you the strength. Now the veins, on the other hand, they don't do the same thing at all. In fact, they're kind of just like empty space before it gets back to the heart. We call it the capacitance system. So arteries resist, and veins are a pool. That pool basically holds all the preload, is the term we use. So all the stuff that's going to go back to the heart eventually, we got to give it a place to be a holding tank. Now, if you think about Lake Mead, that basically feeds the Hoover Dam, if that lake was all right there right now at the Hoover Dam, it wouldn't know what to do with all that volume, right? It's too much right now, but if you let it slowly fill in, then it can keep working. So you need to keep that constant gradient of flow back in there. You need to have savings accounts, so to speak. Otherwise, you're automatically going to zero and having issues. You got to have a little bit of working capital. So that's what the capacitance system of the veins do. A lot of the blood you have is stored in the large veins in the legs. So when you get up and stand up with your patients, if they have intact vein networks, so your deep veins and your shallow veins, they all work on having valves where the arteries don't, right? So I know this is really basic, concepts. When you think about it, you go, okay, if I stand up, the blood should stay there or kind of keep on moving up like a Jacob's ladder towards my heart, right? Every time it pumps, it goes up and stops, goes up and stops. But if I have poor venous flow or venous insufficiency or valvular dysfunction in the legs, all of a sudden it goes back down to the feet, and then the heart gets what sometimes seems like orthostatic symptoms. And all of a sudden they're just like, I feel like I'm going to pass out. And you go, well, you're euvolemic. You've got 3+ edema. What are you talking about? You don't possibly need more volume. It's like, well, yeah, but you don't have it staying where it's supposed to. It basically was going up and up and up and down it went. So the heart didn't see it, is all that mattered. So think of that in your mind when you're doing your nursing care. Make sure you're thinking about things like TEDs or SCDs and things that can help mechanically keep that stuff moving, or vascular surgery for people to get that fixed. That's a big deal. It took me a while to kind of click that in when I have patients that are post-surgical that are actually intravascularly dry, although they have tree trunks that they're walking on. You go, whoa, they got volume. I was like, well, it's not in the right place. It's all third space. It's not in the pipes. So just keep that in mind. Central venous pressure, pretty simple concept. Right where all the blood from all those veins make it to the Hoover Dam, wherever they come right into the heart, that's your central venous pressure. That's going to give you the most accurate representation of how much pressure and volume coming in you have of that leak, of how tall is the water in feet, how much do you have coming in. And in fact, if you lay your patient on their back, you can put them about semi-Fowlers, and you can actually take a graduated cylinder, and if you're an old school nurse from back when you had glass things, you could take a thing and actually measure how much pressure they had in in centimeters above the notch there. So you can actually physically do stuff that you get a number for in a machine with old glass Pyrex equipment. So it really is, how tall is the lake? How many feet are there in the lake? I'm not that old, but that's not that long ago. All right, so what are some signs of inadequate cellular volume? Well, you see these people all the time, right? These are people that have been out running a marathon and they come in and they're like, they're gaunt. Or they're people that have been sitting in their room 85 degrees and it's 95 degrees outside and they haven't had anything but some toast in the morning and some coffee or some nice tea to make them diarrhea some more. So they're sunken eyes, dry skin, dry mucous membranes. When I think about assessing a patient, do I give them volume? Do I give them pressures? What am I doing? I always think about looking around you. You always have examples of what we're trying to do in nature. And I like looking at this like making wine. If you had, imagine yourself right now, you're somewhere in Italy. Not bad, right? Okay. So you look out, beautiful morning. You look to the left, you see some guy, hey, Cecilia! Over here, you're making wine over there. That's cool. But you look down in the vat, like you have up here, and you go, there's a bunch of raisins. Guys, you can do it all day long, but you're not going to make wine out of raisins, right? You need to have the fluid in there to actually make the wine, right? Don't you know that? Hey, it's a good. 8 hours later, you're still squishing on them, still raisins. So the point is, you can do something thinking it's a nice idea, but unless you understand the concept of why you're doing it, it's not going to make it better. For fluid volume, you have to make sure those cells are full of fluid. Otherwise, they're not going to be able to perform the cellular functions. Okay, so in your patients, you have to have cellular volume before you squeeze them. Otherwise, you're squeezing a raisin. Nothing's going to come out of a raisin if you squeeze it. Just isn't going to, right? You're not going to make wine out of that. But if your patient has very apparently full cells, CVP is good, you know, they're ready to squeeze, they're going to benefit from squeezing them. They're actually going to have a net result of actually making cellular progress. Those are the people you give pressors to. And really commonly, what happens is that silly scenario in your mind, you would never see people that actually know what they're doing jumping out of a bunch of raisins hoping to get wine. But it happens all the time in medicine. You have people that are not paying attention, they go, oh, just give them some dopamine. Why? This patient hasn't had any need for dopamine probably in their life and probably never will. Why are you putting someone on vasoactive support when they're probably just dry? Right? So you're not ready to be squeezed until you've proven that you're wet first, in my opinion. So keep that in mind as a simple analogy. Some people don't think about the obvious scenario, how silly that is, but truly it is that silly. So fluid resuscitation, there's lots of different ways to go about this. And there's lots of different ideologies, and I'm not going to tell you there's one better option than another. I'm just going to tell you the options, because where you work, it's not necessarily going to be your option to choose. Your job is to follow the order. And I'm not going to try to make you think beyond, and I don't want you to go back to where you work and say, well, they said to use this instead. Not the point, but there are going to be a lot of people that will have different views on this, and they're typically 20 or 30 years of views that are behind it, and you're not going to change them. But that said, keep in mind what we know about medicine is more than what someone thinks of for 20 or 30 years. So you can always do your job as a change agent to kind of push it and say, you know, I know you like to use albumin, or I know you like to use normal saline, or you like to use hetastarch or whatever. But, ... There's always a ... for pretty much everything. That's the whole point of evidence-based medicine. Don't be afraid to stick your neck out for what you know is right. That said, LR, Normasol, there's all kinds of solutions that you kind of see used a little less frequently, but they're phenomenal. Crystalloids versus colloids, we'll make it real simple. Crystalloids basically are things that if you were to put them in a Pyrex beaker and heat them up, they'd make a bunch of salt, some sort of salt, some kind of thing would precipitate and it would look like a really cool modern art sculpture. Like that thing of glasses back there, it's very organized and it looks really neat. Where colloids are actually protein-based. Colloids are actually theoretically more likely to stay in your blood vessels, where crystalloids tend to kind of go everywhere. One very common way to look at crystalloids is when you give normal saline or LR or anything that's basically made out of water plus some elemental stuff, it's going to go everywhere that it can, because those elements can theoretically go anywhere they want. And the concept of that is called transcapillary refill. A third of it's going to stay in the blood vessel, a third of it's going to go into the intracellular space, and a third of it's going to go into the extracellular space. It kind of just goes everywhere. So that's cool, but at the same time, you're going to have a patient who will be more edematous. And that's not necessarily a good thing depending on the patient. Now, if they already come in with 3+ pitting edema and they're short of breath, but they are apparently intravascularly depleted, right? It's just not all staying where it's supposed to be. The heart's not getting it. You may want to use something that's not going to cause all those other kinds of fluid issues. You might want to use a colloid or a blood product that you know is more likely to stay in the pipes. Now I say likely because colloids, so albumin is the biggest one we'd see there, 5% albumin, sometimes 25% albumin if you want a more dense volume of it. You'll get more oncotic pressure from that. It's going to have the ability to have gravity. So when you put those molecules, the best option is blood, right? You put a molecule of blood and you put water around it, what's it going to do? It's going to say, draw it towards it. It has gravity like walking on the moon. It'll actually pull things in. The osmolar pull of the vessel towards that will actually basically suck all that stuff around it into the blood vessel, because it has a natural process with osmosis to say, normalize everything. I want to have the outer, inner, intra-space all kind of the same thing. In order to do that, you have to have a gradient. You have to have a vacuum cleaner. Suck it in here. That's what albumin does for you. However, keep in mind, you have to have vessels that are intact. Otherwise, it's just going to leak out everywhere else and just cause the same exact process and cost more money. And because it is a blood product or derivative, it costs more and has more negative potential implications for the patient. So keep it in mind, you have to have pipes that are closed that don't have leaks. Otherwise, what's the point? If you're septic and you give a bunch of albumin, guess where it's going to go? Everywhere. So you have to know what the patient can tolerate. Now, a great example of that, burn patients, my goodness, if you have an open cellular network, you're going to lose volume. You're going to lose volume like crazy. And if you've ever worked in the burn area, I worked briefly in a burn trauma area in Rockford, Illinois. And one of the things they did there was a lot of the Parkland formula. And Parkland, not just a college, is a phenomenal, we both went there, I was making a dork joke. 4 milliliters times the body surface area burned times their kilograms in weight. Just so, if you never used it before, you probably had to calculate it in nursing school, right? But you imagine you have a 70 kilogram patient, and so basically, let's say they get 10% burn. So one arm is about 18% burn. Let's say, just make it easy math, 10% burn. So 10% times 40 mLs times, say 100 kilos. So that's, how much is that? That's 4 liters. So I got to give 4 liters and said half is in the first 8 hours. So in 8 hours, I have to give 2 liters of volume to a patient. That doesn't seem so bad, right? That seems reasonable. What if I have a 50% burn for the body? Grab the saline, you're going to be pouring in like crazy. And the whole point is you have to give it so quick because of that insensible loss. The body is like an open chest in surgery. You cut someone's incision and leave it open in surgery, you're going through a liter every single hour just of insensible loss. Your body's just pouring out that heat and it's gone. You'll never get it back. So just keep it in mind. You don't see it happening, but right now, as you're sitting here, in the course of a day here, you're going to lose a half a liter just by breathing. I'm probably going to lose more because I'm talking more, right? So everybody needs to keep rehydrating because of that, and that's one of the things that a lot of people don't do effectively. Okay, so back to school. Your beta 1 receptors are found on the, so go ahead and turn your little guys back on here because they'll automatically turn off on you. Okay, I'm going to make this an ABCD question again. Don't answer yet. Okay, go ahead and answer. Beta 1 receptors are found on the, okay, a couple still clicking in. Okay, good enough. Let's see what we got here. It appears that of the 27 people that responded, 3 think that it is A on the lungs, 22 think that it is B on the heart, 1 thinks it is C on the pancreas, and 1 thinks it's D on the brain. So, what's the right answer? One heart. Beta 1 heart. That's what they told me, so it's got to be right? Yes, it is the heart, but that said, it's a trick question because it's also found on the lungs too. So those receptors are not so specific that they are all in one spot, but they are most aggressively found on the heart. You'll see some on the lungs too, which is one of the reasons that some of the more first generation level medicines, the ones that have more interactions, those are the ones that you'll find that aren't as specific to being truly beta 1 selective or cardioselective. They say that they're cardioselective, but that said, you may still have someone who has an asthma history take a cardioselective beta blocker and still have an asthma problem because it's causing them to bronchoconstrict. Everyone's different. Those concentrations are different in most people, but as a general rule, they're mostly on the heart. Beta 1 heart, beta 2 lungs. Okay. Just want to keep that in mind because that's one of those things that there's never an always in medicine, right? There's these things you go, it's always. It's like, it's not quite that much. All right, good job, everybody. So sympathetic receptors, we'll talk about alphas and betas really quickly. Alpha 1 and alpha 2 and beta 1 and beta 2. They're not the same. Okay, they don't work the same. They don't have the same process for 1 and 2. So keep that in mind. Alpha 1 is like the on switch. Alpha 2 is like the off switch for alphas. Beta 1, beta 2, they're both on switches. Okay, so alpha 1, the way I think of this is alpha arm. Okay, so if you see someone that's doing curls or going to the gym, getting gunned up, that's basically gonna squeeze down. That's giving you that excitatory neurologic state where everything is tightened up. Now, I also put in there the excitatory neurologic state. So one thing that happens when you imagine the whole sympathetic response, right? Our bodies were designed to do some pretty cool things, but there's some things that are not what you really have to think about, right? That's the whole concept of sympathetic response. You're not actually saying, body breathe. Oh, thank you for the heart beating. I'm going to run away from this creepo, so you better give me some speed, heart. Yeah. These things happen automatically, right? That's the whole concept of how it works. It's a very primitive function of the body, which is awesome. You wake up late for a meeting, you wake up and your heart's beating fast, or someone knocks on the door, scary movie. We've all had it happen to us. When you experience that, it's an excitatory neurologic state as well. It's not just that, oh yes, I feel my heart beating, but I'm late for work. This is wonderful. No, you go, ah, and freak out, right? The idea is the response does cross the blood-brain barrier. And when that happens, it's designed for you to deal with an immediate physiologic response, for the sympathetic response. The exact opposite. The parasympathetic response is exactly the opposite. That's basically going to calm you down and chill you out. We talk about I'm sure you've all heard the fight or flight mechanism for the sympathetic, or the feed and breed for the parasympathetic. There's all kinds of funny versions of that. But the idea is the response in your body does go to your brain as well. And the medicines that you're using, they have a potential to do that as well. So think about that. Alpha-2 is basically, like I said, it's the off switch for the response. So that's basically like your body is going to win. It's basically going to be a bigger force with the alpha-1. And then if you give medicine to relax it, then the arm swings the other direction. How'd you like to meet her in the bar, man? It's legit. Okay, so they're always in a wrestling match, though, the alpha-1 and alpha-2. They're kind of deciding who's winning, who's losing, and you can help it out. One of the things that you can use that will be a blockade of alpha-1 or an alpha-2 stimulant, basically causing the same response. It's a teeter-totter, right? You're just pushing the balance here, is Precedex, or dexmedetomidine. This is a medicine that gets used a lot for analgesia, post-procedural sedation, ventilator management. These are things alcohol withdrawal is fantastic for. Raise your hand if you used those before or heard that before. Precedex, yeah, it's a good drug. Example of that is it actually crosses the blood-brain barrier. And we know that because people use it as a sedation mechanism, right? But it's actually designed to relax your pipes, and they found out that it makes you sleepy. So kind of crazy, right? Side effects have benefits sometimes. So that is how that one will give you, again, if you treat it from the opposite direction, we're going to use it as a sedation. Its negative side effect is, oh, it's going to cause your blood pressure to drop. Well, yeah, because it's doing the same thing. It's the same parasympathetic reaction. Or in that case, a sympathetic blocker. So beta-1 receptors, yes, stimulate one heart, but also, remember, it can be elsewhere too. Increases your heart rate, contractility force, and the conduction velocity, and the likelihood for ectopy too. So keep that in mind. You're given these drugs, but they are basically making your heart like a loose cannon. And yes, beta-1, one heart. Beta-2, oh, 2 lungs. Like my clip art. Is that funny? I was going to make you do some stuff, but I decided, I'm not going to make you do stuff. Beta-2 receptors, pretty much everyone's heard of albuterol, right? We give something to stimulate the lungs to open up and work better. Causes bronchodilation. If you're going to go fight a bear, you need some more oxygen flowing in, right? You got to keep that going. And while you're fighting that bear, you need your skin to kind of tense up and basically close down so that if you get cut by the bear, it's not going to bleed. So that causes you to have a peripheral vasoconstriction of the skin. You get that cool, pale, and clammy. It's basically your bulletproof shield. That's the whole point of that. And then the pipes beneath those, they actually have increased blood flow going to the muscles. So it's pretty cool. You get this outer lining of skin that shuts down, the muscles underneath it that go wake up, give you plenty of strength to go fight, and your brain goes boom, you freak out, and you get tunnel vision on purpose. So I got to fight that bear. I don't really care about that bear. I care about that bear. And that bear's like, you're dead anyway. But it's okay. Coronary artery dilation, it opens the pipes up. It makes things work better. It basically tells your organs, wake up, it's time to go. Your insulin is going to get dumped out like crazy. However, it's not going to be enough. Your liver is going to dump out like crazy, and you're basically going to get this mass surplus of sugar designed for a quick sugar rush. That's great, whatever, but the problem is if you have a long-term stress of this, like a big surgery, like cardiothoracic surgery is a really good example, you'll need to have insulin to supplement that process. The body's stress response is just not capable of meeting that demand in most patients. You need to have something to bring that sugar down, because the sugar will be 400 or 500 if you let it sometimes. You gotta be very careful. You wanna keep that controlled. So the dopaminergic receptors. You have a lot more than you probably have heard of. I'm going to briefly talk about them. And in brief, the most common ones are the D1 receptors for people that are in their brain. And then your D2 and D3 are the ones that we tend to see the response of if we give low-dose dopamine, because those are going to give more blood flow to the basically your mesentery and your kidneys and your retroperitoneum, effectively. Hey, he's happy. So you think about the D1 receptors. If we're going to give dopamine in a bag, right, we just take it out. Step one, have you ever smelled the inside of a dopamine bag? What is with that stuff they put on it? It's not in any other bag. It's just dopamine. It's so bad. It's really bad. Okay, anyway, so we don't really care so much about the D1 D1 receptor stimulation when we are dealing with giving a bag of dopa. Why? Because it's a different receptor, and it's not really the medicine we're worried about. But just keep it in mind, you're not going to have your patient all of a sudden be like anti-Parkinsonian because you're giving him a bag of dopa. Okay? It doesn't cross the blood-brain barrier in that specific created fashion. It's not going to affect it the same way. But that said, in lower dose, you'll see the dosing happen, and then in higher doses, you'll see it affect other organs as well. So my wife is a Packers fan. I am not. So we live closer to Wisconsin than we did living down here. And one of the things that you do see when you get closer to Wisconsin is more brokenness. You see these people that basically spend a lot of time wearing cheese hats. Okay, they like their supper clubs. They like their these little things you go to where you think you're going to get good food, but you don't. And the concept is to see how big of a margarita you can get in Champaign-Urbana. Up there, it's these things called Bloody Marys that can be this tall. They're insane. They have like a full fried chicken off the side of them on a fork, and you're like, are you kidding me? But that's normal up there, and you start drinking when you wake up, not when you go to sleep. So it's a different kind of world. And that said, they have a lot of cheese. So fortunately down here we have better, we get it more, the Central Illinois people. I'm just kidding. I'm a Bears fan, so what do I know? So catecholamines are derived from tyrosine. So tyrosine is the cheesiest amino acid because guess what? It makes cheese. But it also makes all kinds of cool things like all of our innate pressors. So this is pretty crazy. This is a little throwback to some history for you. This German chemist, this Justus von Liebig, what a great name, man, Liebig. He found that in all these animal proteins, soys, dairy, lima beans, and sesame seeds, they also have this amino acid that's basically a common thing. But the biggest thing is how he created this word. So it's pretty cool. So tyrosine is a Greek word from cheese that he put together, and it's something that they found later has considerable effects on our whole body. So basically, if you're from Wisconsin, talk about what's an essential versus a non-essential amino acid. A non-essential amino acid is something your body's not going to have on its own. It's not going to create it. But if it's an essential amino acid, it's something your body makes on its own. You don't need to supplement it to get it, right? Well, if you're in Wisconsin, you can never have enough cheese. So I make the joke that if you're in Wisconsin, I'm sorry, I said it backwards. It is an essential amino acid. You have to have it. You can't get it without getting cheese. So anyway, so tyrosine hydrolyzes to create L-DOPA. Basically, the breakdown is L-DOPA or levodopa, dopamine, norepinephrine, and then epinephrine. These are things that we can give in a bag, right? But these are things your body makes naturally. So eating foods with tyrosine is a no-no if you're on MAOIs. But that said, we don't really see a lot of MAOIs anymore. Monoamine oxidase inhibitors used to be a neurologic drug that worked on purpose by basically slowing down the process of how you recycle different medicines and different specifically neurotransmitters. So if those neurotransmitters normally go from A to B, kind of like your urine, you drink water and you pee it out. Drink water, pee it out. Well, if you don't want to pee out so much, you take some antidiuretic hormone, you don't pee as much. Well, the same thing happens. If I don't feel good, let me take something that makes my brain hold on to those feel-good things longer. I'll basically recycle it in my system, like antidiuretic hormone with urine. Same thing is called MAOI. And monoamine oxidization is how you break down from levodopa to dopamine to norepinephrine to epinephrine. So that's how that works. Pretty cool. So why do some medications cause more neurologic effects than others? Let me get this up here so we can play with it. All right, so go for it. What do you think? A, concentration or dosing used. B, generation of the drug. C, molecule size. D, permeability of the blood-brain barrier. Or E, all the above. Okay, I've only got 3 people that have voted, so lots of head scratching happening right now. It's okay, it's a great question. I have 5 people that have answered, literally. Did you turn it off or turn them on? Okay, turn them on every time. These are actually designed for kids like in elementary school. They're phenomenal. I can even make a little Student of the Day award. It's kind of cool. All right, so from the massive 5 people that voted, it didn't actually go through, I guess. So everyone thinks it's all the above. So, yay, you got it right. Yes, it is all the above. And the reason for that is kind of what we talked about. So certain things don't get a serum level unless you get a certain volume. So you can give acetaminophen to patients all you want until you get to a toxic oral dose. It doesn't actually cause a neurologic effect that makes much difference other than just taking the edge off the pain. But if you give it in a higher dose, it actually has some incredible neurologic properties to take away pain, which is how a drug that's called Ofirmev came out. It's IV acetaminophen, so paracetamol, it's been around in Britain forever. But the idea is if you can bypass the liver and get a higher concentration in your system, it'll actually have the response based on the concentration it can create that the liver was stopping from happening in what was otherwise the only safe dose you could get, which again is 4 grams in 24 hours and all that. You would have to take all 4 grams in one dose to really get that same level. Without the lethal doses, you can take it IV and look at that. Wow, how cool is that? Generation of the drug. Certain generations do or don't have the blood-brain barrier mechanism. So it depends. Like for example, a really good example of this is people that have headaches. They take a drug called Inderal or propranolol. Propranolol is a beta blocker, right? Well, it just so happens it does happen to be the type of molecule that will cross the blood-brain barrier. It is small enough of a molecule, and it's the type of molecule that is lipophilic, which means that it loves the fat, which you need to get in there, and it's small enough to sneak in there. So the brain goes, you know, I was kind of jittery before this talk, but now I took a pill and now I feel a little better. For performance anxiety, public speaking, musical theater, a lot of people take Inderal because they get the jitters before. So the whole concept there is it has gotten across the blood-brain barrier. And then the permeability is a thing too. So if you have someone who has a really impermeable blood-brain barrier for whatever reason, that would stop it. But typically that's a fairly fixed thing on everybody. You can benchmark that. So yes, E, all the above. Yay. Okay, so that's a lot of stuff to say, right? What do we do with that? How do we actually take from understanding what we're going to be giving, we understand that we should give volume first. When do you give volume first? When do you give the pressure first? Well, here's a general rule. If your CVP is in a perfect state, and it never is, you would go until that number is the higher end of your normal limit. You know, that may be 2 to 6 in your book, it may be 10, maybe 15. The patient may come in with a history of CHF and they live at 20. So how do you know what it is, right? You have to benchmark the patient. You have to have a good reference of your patient longitudinally. If you give them volume, the other way to do it is simply say, let's see if we give you some volume by lifting your legs with a passive volume raise. Just kind of let gravity help, right? Take their feet, raise them up, and just kind of hold them up there. Take the tree trunks up and just see what happens. If they have an increase in, now, step one, if you actually have a way to measure this, it's a lot easier, right? So if you don't have anything but a blood pressure, it's not as exact of a science, but we got you covered too. I'm going to tell you how. If you have ways to measure this, cardiac output, cardiac index, SVR, CVP, these are all things that we're looking for. If you have a central line in, raise the legs up and see, does your CVP go up? If it goes up, then the next thing is, okay, if that went up, what did my blood pressure do with it? Did it get better? And what you really want is your mean arterial pressure, right? We all know that that's more important than your blood pressure. However, if you don't have all the whiz-bang bells and whistles, but you do have a way of hopefully at least having an arterial line in a patient that's this thick, or going to be getting a line in someone that's this thick, get a blood pressure and basically look for the best and worst blood pressure as they take a deep breath in and out. Okay, so as you breathe, what's happening intrathoracically is you're moving in and out, you're pumping the blood in your chest through the lungs, it's being squished back towards the heart. And if you take a breath in and your pulse is going up and down, that paradoxical movement of the systolic amplitude creates a trough. If you go to the very tallest to the very lowest of those, that gives you a little, like say your best blood pressure is 120 and your worst blood pressure is 90. That's a 30-point difference. That's considerable, right? That difference, if it's more than 10%, which that is way more than 10%, right? If it's more than 10%, you're clinically dry. That is so old school, but it still works, okay? If you have more invasive monitoring, you can do that with something called SVV. Some people use it, some people don't, but stroke volume variance, that's what that is. That's literally what that is, except it's one step before you're measuring it in the body. That's just measuring it in the stroke volume and how much difference there is and how much it's actually squirting out. Well, the next step of squirting it out is going to the body, right? So it's the same thing. So just keep that in mind. You have mechanisms that are actually going to tell you, did they respond to the fluid without actually having to pour more fluid on the patient. Just use their legs, raise them up. It's not forever fixed because what happens when you put their legs back down? It's going back down, right? But that is an easy way to tell. Now, what happens if they do respond? Their pressure does get better. Great, give them some more. Actually say, hey, doc, I did a passive, this is a nursing level skill too. If you have a patient that can tolerate it, you don't have to have an order to lift someone's legs up, right? So raise your legs up and, oh, look at that, they did respond well. Hey, by the way, you just ordered a whole bunch of dopamine. Their heart rate's already 130. I'm kind of thinking you may not want to give something that's going to go, it's like too much heart rate right now. You need to kind of fill the heart and then squeeze it out. Get some more volume first. Oh, I think they're euvolemic. No, they're not. They're not euvolemic. They're not anything. Give them some volume because I just lifted their legs and their pressure and their heart rate normalized. They're like in stage 1 shock. They need more filled. Oh, okay. Okay, let's keep that in mind. Every doctor talks about it. Oh, okay. Especially when you tell them something that they didn't want to hear, but they should have heard. Anyway, septic shock is different, but let's talk about cardiogenic shock first. You may or may not have a normal CVP. And my point of that is the patient needs to be trended. You need to know what their normal is because, again, they may be dry one day and wet the next day, and their CVP may be all over. The question is, did they respond to what you're doing? We have people that are post-op all the time, they're bleeding, right? You had surgery, you're going to be bleeding. I assume you need volume first. Step 1 is always give volume first. Step 2 is, do they respond to the volume? If yes, give more volume if you need to. And after that is, I've given a lot of volume. Should I be giving blood instead of just giving something less than blood? Otherwise, I'm just diluting everything and they're going to bleed more. At a certain point, I stop the bleeding. Life's great. 2 days later, guess what? I'm going to probably start diuresing you because of all the extra fluid I gave you. But maybe I diurese you too much, and now you're dry again. You stand up and you go, start passing out on me. Okay, I need to give you more volume back. Again, my point is it's a dynamic thing. It goes like this. Every patient's different. They didn't eat it all this day. They didn't drink enough that day, or we gave them too much Lasix that day. And most of medicine is the people that are taking care of the patient screwing the patient up until they get to go home and fix themselves. So you just kind of don't be your worst enemy by trying to do something. Because sometimes just talking to the patient is the best thing that's going to help their blood pressure. And just kind of chill and say, I'm not going to do anything to you today because the more I do, the more I'm just messing you up. Because you know what happens? You give them Lasix, they go and drink more, right? Because they feel thirsty. They want to drink more because their body's telling them to. And all you did is basically the volume went from 0 in, 0 out as the net for the day. And they basically just lost potassium out of the deal. And you're just giving them potassium powder now for no reason. It's like, what did you do for this patient? You did nothing. So keep it in mind, you don't have to necessarily do something. Sometimes nothing is okay. But if your patient has a low blood pressure, what are you going to do? I'm going to jump down to the cardiogenic shock one here. Pulmonary artery wedge pressure, you may or may not have access to that, but that's basically the filling pressure coming into the left side of the heart and end diastolic pressure to the ventricle. So when the left side of the heart squeezes out, it's like, systolic pressure. But then when it relaxes, it goes from like nothing to all of that. It's like nothing, everything, nothing, everything. So when it's doing nothing, it's actually like a vacuum from the lungs pulling it in there. It's like 2 or 3 is a good EDP, and it basically should just be like pouring in there. There's no air in there. It's not like you're pouring a pitcher in there. It's under a vacuum. But that said, there's not a lot that really fills it. So you don't need a lot of pressure there. But if that's really low, that can tell you, okay, you need more fluid. What happens if it's up there? That's telling you that your heart can't keep up with it. It's pushing it in too much, and I got nowhere to go with it. What am I going to do? Your output's low. I've got someone pushing me. It's like when I always think of the picture of the running of the bulls. There's always that one guy who's like way out front, and he's like, ah! He's on adrenaline, and he's way out there. And then there's a whole line of people that are getting like pushed by the animals that can't keep up. And it's like, if you get ahead of it, cool, you're out of shock. But otherwise, you're just stuck being pushed along with shock. There's nothing you can do is just go along for the ride. So your heart's basically got all this fluid coming in. It's like, I can't keep up with you. Well, you don't want to give someone who has too much fluid more fluid, right? So if you're in cryogenic shock, your only option is to give a pressor. If you're in septic shock, on the other hand, though, your pipes have just relaxed. You have nothing but open hoses. All you can do at that point is say, I need to fill these hoses so they actually fill up, and then I can try squeezing them and see what happens. And the same thing goes with hypovolemic shock. It's the same state. Always fill the pipes first. The reason I mentioned cryogenic shock first, because it's so uniquely different. You have to make sure you listen to your patient. You have to listen to their lungs. You have to actually evaluate them. I don't care if you have fluid in your legs. That's not going to kill you. You're not going to get hypoxic because your legs are puffy. But if your lungs are, I got a bad day. You may get intubated. You may die. I can't always fix you with Lasix. You know what I mean? So you need to make sure that you know your patient's actually not wet in their lungs before you just go down the road saying, give them volume, give them volume. And guess what? If you do a passive leg raise on a patient who is in CHF, you'll know real quick. They won't, for one, like to lie flat, and then 2, just about die on you when you start doing it. And that's okay, because then you set their legs down and sit them back up and say, okay, we know, but we didn't change your volume to do that. We just did a very simple intra-cavity test. Okay, just keep that in mind. And then, obviously, your end results are going to be what drugs you want to use. Now, I'll be the first one to tell you that there's no perfect science of what to use when first and where you go. Every doctor has their own thing. But let's talk quickly about the options. This is just a little quick reference guide for you. Dopamine's real common, right? Now, I specifically made these handouts as small as possible, so it was impossible for you to read these. So good luck with that. But the concentration, dose, those are all things that are going to be facility specific. The low, medium, or high dose, again, these are arbitrary per patient. The 2 to 5, 5 to 10, or 10 to 30 mic per kilo per minute dosings, they have an ascending response to the body in dopamine. So just keep that in mind. You may hear something called low dose dopamine. Low dose dopamine is a nice idea to get the kidneys, like we talked about, the D2, D3 receptors that actually are fed by those. It feeds them a little bit more, gets more blood flow to them, and ideally can make them perfuse more so the kidneys work a little better. Well, they don't work any better. They don't actually do anything more. They just basically, you know, it's like washing your car more. It doesn't make it cleaner, just it's been washed more. So it doesn't really increase your creatinine clearance. It doesn't actually do anything to actually improve the function of the organ itself, but it does sometimes cause you to be more permeable to volume. So what tends to happen is patients will make more urine, and it makes people excited. They go, yeah, they're making urine, that's great. Yeah, but you didn't actually help their kidneys. You didn't actually improve the glomerular filtration rate. You didn't actually clear any creatinine or BUN. It didn't do anything. All it did is basically give more volume into the patient to make more volume come out. It's not necessarily a super fix. However, if you're hypotensive and the organ's not getting enough blood flow, period, because your pressure sucks, that's a different story. You can actually help them out by giving them volume, and then all of a sudden, yeah, they're getting what they need. All of a sudden, they kick out a ton of urine, their creatinine's better. Yeah, they were just hypotensive. Different story. But that said, keep in mind there's one other situation where your kidneys may not get good blood flow. It's called renal artery stenosis. And some people have this, and it's a very common cause for people to have uncontrolled hypertension. And people that have hypertension don't always have a way to fix it. They take a lot of medicines, but they come in for surgeries and procedures. They come in the hospital in different crisis states. They may not have enough to keep the flow in. They may be basically not getting any flow to the kidneys, so this may be used to help get the good flow in. So keep that in mind. Dopamine is a good drug, although it does have very considerable risk of arrhythmias because, again, it's going to drive the heart faster. Beta 1, one heart. Yeah, give it that crank it up. Oh yeah, it's going faster. Yeah, pressure is going to go up. But all of a sudden, we're going to start throwing ectopy. We're going to have lightning bolts everywhere. Not necessarily good for the patient if they already are tachycardic. So keep that in mind. Dobutamine is very similar to, it's a sympathetic agonist. So dopamine, very similar to dobutamine, except for dobutamine is one that you'll see used typically not as a monotherapy. And the reason I say monotherapy is not ever going to be it's only the thing on there. Typically, it's going to be dopamine plus dobutamine, or they'll put this on in addition and then wean it off first and kind of get it out of the way. What's the purpose of dobutamine? Well, dobutamine does all the things that dopamine does, except for it doesn't cause you to have the systemic vascular resistance squeeze peripherally in the high dose. So the idea is that it actually reduces the preload of the patient, and you'll actually drop your blood pressure. So you'll never see someone that has a clue pick this drug as a monotherapy if your patient's hypotensive. In fact, you can use it when their heart's kind of in shock state, not really pumping very well, and you want to say, man, I got that garden hose, I'm trying to pump against my finger to get it out to the garden, but I just don't have enough strength. I can't turn the knob up to make the water supply better. Dobutamine is going to turn the water supply up, make it work a little better, and then at the same time it takes the finger off the hose so it can flow a little better. But when you do that, remember the finger off the hose means not as much pressure coming out, so you lose blood pressure. So you can use that, plus you can also use other medicines at the same time. So a little dopa and dobutamine at the same time will give you some response. So again, the concept is you got to find what the patient needs. There's no magic little potion, and whoever orders these is actually in charge of deciding this. It's not you, but it is you to titrate them. It is you to decide how the patient responds, and it is certainly up to you to decide if something's going wrong. Wait a minute, we got to pull the plug on this. You got to recognize and trend what's going on. It's also very one of the specific implications of your alphas are, I didn't put it in here, but neosynephrine is another drug used, or phenylephrine. Very common drug to use that's more of an alpha and not a beta at all. Now, some people still get a little more tachycardic. Again, why? Because we have alpha and beta receptors that are kind of everywhere, but they're most concentrated in those areas we talked about. For the arms, for the alpha, you do have alpha responses more locally too, but beta 1 on your heart, beta 2 on your lungs, there's also alpha in there too. So you can have someone have a response from a drug and you say, well, it shouldn't be causing that. Everyone's different, okay? But that said, for phenylephrine, that drug is more alpha, where you take Levophed and take away the beta, where it's squeezing the heart, making you go faster. That's more what phenylephrine does. Phenylephrine is not used a lot of times in patients as a monotherapy when you need heart rate support also, because it doesn't do that, where Levophed would. However, if you have a patient that's basically, their heart rate's like 130, right? They're in septic shock. I would probably go to that first with neosynephrine. Why? Because I'm going to squeeze the pipes, because that's what they need. Their body relax the pipes. I'm going to squeeze the pipes to fix it. And when you do that, you're actually going to see that heart rate come down, because the body says, okay, I don't need to do this anymore. My heart rate's better. Life's good. That response is something that is different for everybody. There's no guarantee on how that's going to be, but that's the whole point of the order says titrate. You know, you have to figure that out. Adrenaline. Let's see if this will work here. I'm not sure it's going to like that. It's not going to let me. So I want to play this clip. This is a clip from someone made a spin-off of the Say Something scene from Pulp Fiction, where they stab her right in the heart with the epinephrine intracardiac needle. And someone made a really funny version of it with a pop can as a syringe, and it's really ghetto, but apparently it's not working because I'm recording, so I apologize. But either way, I'll see if I can make it play. It's pretty funny. Epi is a great drug too, but Epi also has a ton of cardiac side effects, right? It makes you pro-arrhythmic to beat the band. If you're using Epi as a first-line drug, you're doing something wrong, okay? Epi is there for life-saving measures if you give it IV push, but you can give it as a drip, and it will definitely increase your heart rate. However, one of the really, really nasty side effects of this is it's going to make you acidotic, guaranteed. I don't care who you are, your body is not happy when you're getting Epi in it, period. You're not going to feel good, you're going to have end-organ dysfunction, it's going to mess with your kidneys, it's going to mess with your sugars, will go wild. You just don't want to use this unless you need to. However, there's some people you need to use it. A lot of times it's going to be, give them some Levo. Does that help? No? Okay. Give them Levo plus some Dopa, or give them some Dopa with or without the Levo, and then keep on adding and keep on going until you get the response. And a lot of times you'll find that Epi used in a very low dose as just like the very last agent will be helpful. Vasopressin works a little different. The vasopressin has become a lot more popular than it used to be. In fact, vasopressin used to be thought to be in the most recent, the penultimate, so the one before the most recent version of ACLS was you can give 1 dose of vasopressin, right? IV 40 push, because it may be equivalent to epinephrine IV. Well, why do they say that? Well, the difference is, yeah, it's going to squeeze, and if you give that much of it, yeah, it's going to squeeze. But the question is, does it actually improve the outcomes or not? And when you look at what vasopressin does, it has a different mechanism by which it works. So there's times when it might work when the pressors don't. And I want to point those out because it kind of went out of vogue again, but it really does have a place. And it still gets used a lot as a pressor, but just kind of keep in mind the specific rule here. If your pH is really low, right, like we talked about, if your pH is less than 6.9, all those other tyrosine derivatives, they don't like to work as well. So epinephrine, Levophed, dopamine, dobutamine, they just don't tend to get good cellular response because they don't have a binding affinity. Vasopressin doesn't work the same way. Vasopressin is from your pituitary gland, and the way it works is it goes over your whole body and it tells everything neurohormonally to squeeze. Totally different than how it works from the pressors. So because it has a different mechanism in cellular binding, there are times when your pH is really acidic, you may get a response when you wouldn't get a response with the other pressors. So specifically in your mind think, you know, their pH is really low, or man, I'm going up on pressors, nothing's working. I'm giving volume and pressors, I'm trying everything I can, nothing's working. Think vasopressin, because you may find that it's all it takes to get your pressure up. You back off all the other pressors, and it gives a chance for the body to normalize and get off the stuff like the epi, which is going to make you more acidotic, right? Because you kind of go in that spiral, you get more and more acidotic, and then you're dead, right? There's only so much you can do before your organs say, I'm not getting perfused. I'm going to be dead. So thanks. So keep that in mind. And why don't these always work? Talk briefly about that. Hypothermia. So venous stasis, decreased return of medications to central circulation. Yeah, I've had people who were really cold that got medicines peripherally, and they finally got to them when they warmed up. So, happens. How many times have you seen people that you get CPR and they get an epi-pulse, right? They go boom, 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 boom. You know, oh yeah, that's epitac. You know, their heart rate's 150, 160, 200. Whoa! It's like, don't shock it, don't worry about it. It'll go away in a couple minutes. It's just the epi working. Well, you get someone that's, you know, you got really bad CPR, you push all these meds peripherally, nothing happened, and they finally hook up a pressure bag to it, or they finally hook up some volume to it, and then finally gets to the heart, right? And all of a sudden, now it's finally working. So it has to actually get to where it needs to go for it to work. You can't put a whole bunch of medicine in the tubing and expect it to get to the patient. You've got to make sure it's being carried to the patient. And more than not, that's usually the error. We go, why is this patient not getting this? Oh, the tubing's clamped, you know. It happens. I had a pump that let me do that all day long. And they're not supposed to. It's obviously not working properly. But I had a patient that was like, I'm going up on dope, but nothing's working. The pressure was like 80s. I'm like, what's going on? Nothing, no response whatsoever. And the tubing was clamped beneath the pump. But the pump wasn't alarming, which it should alarm, right? It should be going, wait a minute, we're getting occlusion. Had no problem with it. So I finally undid it, and the patient's like, whoa! Pressure shot up. You know, he's feeling great. And I think we're good here. We're going on multiple pressors, and all of a sudden it's like, oh, okay, we're off everything. Everything's great. Whoops. Great, you know, so know your equipment. But again, that's kind of a random thing. Decreased cellular extraction or pump function. Again, if your cells aren't working, they're not going to do anything. If you got raisins, they're not going to be grapes. You got to fill them up. They got to work first. They got to do their job. If the messaging that happens in the cells can't work because the cell's dead, it's not going to get the message from the beta receptor through the cell down to where it actually works. Metabolic acidosis, lactic acidosis. Again, it's an inactivated drug. It's not going to do anything. Solution to pollution solution. It's kind of cute. What do you do? So, okay, well, if it's polluted, diluted, well, you can give volume all day long. You can give bicarb to try to fix an acidosis, but you need to know the source, right? If it's cardiogenic, then fine. If it's lactic acidosis because you have some end organ that's dead, if you have dead gut or something, you need to go to surgery, right? So you need to know the cause if possible. If it's sepsis because you have an infection, well, you need antibiotics. You need time for them to work. Expired or inactivated drug, your drugs aren't any good anymore, you know, that certainly is a big deal, and make sure that you know what they're actually compatible with. Sometimes drugs need some time to go through the tubing to make sure they work well and bind to the tubing, otherwise they will basically soak into the tubing and not the patient. So that's a problem. So make sure you follow the protocols. And then the bedside implications for all pressors. Step one, make sure that you never, ever, ever bolus pressors, because those pressors are not designed to be given that fast. Although you can have a sympathetic response with those so fast, the amount you're giving is way, way, way superseding what your body does on its own. And in fact, you can do all kinds of fun stuff to them if you're not careful. The body has built-in mechanisms to respond to that. One is called the carotid reflex. In your arch of the carotid, you have basically a response where you will get bradycardic if the heart rate's going, you're kind of on a runaway mode. I don't need that. That's way too much pressure. I'm going to slow down. And in fact, if you give someone a high dose bolus of an alpha agonist, you'll see that happen. So if you give a bunch of phenylephrine quick, they'll go boop, the heart rate goes down because the body says, I don't need that help. Now, if you're giving a beta agonist, if you're giving like dopamine, Levo, or epi, you're going to be kind of overdriving and pushing that up. So it's kind of like a self-inhibiting process. So it's like a beta blocker. It's like their heart rate, if you're doing orthostatic vitals, if they're on co-reg or something, you're not going to see a really good orthostatic vital heart rate shift. Why? Because they're on a beta blocker, right? Same thing goes, you're not going to see their heart rate go down if you give it fast because they're on something that's pushing it faster, right? But again, keep that in mind. If you give it really fast, or if you're looking at your patient, everything's great, and all of a sudden you realize that you just free dripping in a phenylephrine, and their heart rate just goes down and down and down, and their pressure is fine. You go, oh crap, gotta run over there and do something about it. Just know that in the back of your head. Don't piggyback a pressor line. It's not uncommon to have a patient that all of a sudden gets little boluses inadvertently because your antibiotic is going in the same line, and all of a sudden it's time to hang some Zosyn, and all of a sudden their pressure is really good. Whoops, don't do that. Always make sure you have a central access if you need it. There's some of these drugs are very, very caustic. Their osmolarity is so high that if you give it peripherally, you can cause irreparable death to that vessel, and that's not okay. If you think about someone who has epi and an extremal digit out here, you can lose the digit. Not okay. You don't want to, that's a big deal, and that goes back to you. Even though the hospital policy may be it's okay, you got to be cognizant of, is that a safe enough IV? Is that a 22 or 24 in the pinky? You're not going to put a pressor through that, right? You got to think, okay, this is an 18 in the AC. Okay, maybe it's all right, but it's still going to be kind of Do you have resources? Do you have someone that can come and put a line for you? Do you have PIC? Do you have central access? Do you have an anesthesiologist? Those are the people that if you have them present, at least go down that road first if possible. I know sometimes it's impossible. I get it. I've been there. It's always right when the PIC nurse is leaving. It's always right when anesthesiology is in a bad mood and the pulmonologist is left for the day. Your intensivist doesn't want to deal with it. It is what it is. You have to advocate for the patient. Okay. Check your site. Make sure that it's not infiltrating because it'll infiltrate quietly. Sometimes these have a little bit of a anesthetic effect to them. So when they go in, the patient feels, oh, it kind of doesn't feel so good, but you don't think about it. It hurts no matter what, if it's infiltrated or not. You look down and it feels okay, or looks okay, and it hurts. And they're like getting potassium bags. Oh, it hurts. Yeah, you're fine. You look down, it's like, oh, yeah, it does. It probably should hurt. So it's kind of the crying wolf thing. You got to be the active one to look and make sure, because sometimes a patient won't be able to tell you it hurts. Sometimes it doesn't hurt. Sometimes it's monstrally, a patient that's on a vent and they're sedated and, they're not going to talk to you. Okay. So, one more time with our little clickers here. If I find my patient is not hypovolemic and they're hypotensive, all right. And go ahead. You all voted? Go on, we got a couple more that haven't. All right, and let's see our results here. I have 24 of you that gave me results, and 2 chose D. Yes, awesome. All right, that's what we hope for. I'm glad that we've provided you with quality education so that you decide to not be in the ICU. That is awful. All right, so that's the end of my specific slides. Are there any questions you have about this stuff? Okay. If you have in front of you the evaluation for this particular talk, please fill this out. You will get this will get 2 hours of continuing education. If you work in a role where you need pharmacology CE, you get 1.5 hours of Pharm CE for this. And when you finish those forms out, please bring them over to Katie, and in the very upper left-hand corner, she'll give you your CE certificate. Once you hand that to her, I need a form filled out for everybody that wants a CE certificate, basically, in order to justify our CE through Ohio Nurses Association. And when you're done with that, go ahead and stand up, take a break, go check out our exhibitors, have some food, I'll put some music on, and then we'll start back up at 9, let's see where we're at in time. We are 9:25, perfect. So 9:45 we'll start back up with our next talk and go from there, okay?